Live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Renal Anomalies, Theory to Practice, and session 9. So it's my privilege to introduce the MOC of today's webinar, Dr. Radhika Gauri ma'am. Ma'am is the specialist consultant in OBG and clinical lead, ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Thank you. I first thank Dr. Ramani ma'am, and Dr. Sampath ma'am, and Dr. Malati ma'am, who's been doing a great job by organizing this TNFOG webinar series for all junior doctors and other consultants about the ultrasound anomalies, and it gives us enriches our knowledge. So let's start the program. Sahiti, can you please? Dr. Malati ma'am, we all know her. She's done her MD, OG, MRC, OG, UK, and Dippan B. She's the director of... Okay, ma'am. So, Dr. Sampath ma'am is not present. We will start the program with the prayer. I invite Dr. Ramani ma'am to give a few words and bless this program. Dr. Ramani ma'am is a National Vice President FOXI 2020, and she is the present President for TNFOG, and she is also the International Advisory Board member for Fertility Society.
Enough. We'll start the program straight. Yes. So, as President of TNFOG, I have great pleasure and honor to welcome all of you for this TNFOG imaging series that has been conducted by Dr. Malati Prasad, and this is the 9th series. She is doing a wonderful work, and we know that renal diseases are next to neural diseases are some of the common conditions what we can pick up in utero, and it is very commonly that pelvic calyceal dilatation that is being often the report given. And actually, as a senior consultant, sometimes we have to call the sonologist and find out what is its real impact upon the impact upon the renal system of the newborn. And another thing is we commonly see agenesis of kidney, hyperplastic kidney, polycystic kidney, displaced kidney, that is ectopic kidney, and a single kidney. And we must always remember that especially in a female fetus, we have to look for 1/3 of these cases are found to have associated Mullerian anomalies. So this will give us an idea for the future of the girl babies also, we can just counsel the parents that this is the situation. Maybe when the girl grows, we have to have a we have to discuss about the impact upon the future. Then some of these renal anomalies are syndromic also. So that also we have to find out. And they are not compatible. Hypoplastic, bilateral hypoplastic kidneys or aplastic kidneys with severe oligohydramnias. They're all not compatible with life. And we have to counsel the couple for termination. I think Dr. Malati Prasad and her team will do an excellent job regarding what are all the common renal anomalies and how should we pick up and how we should counsel. I am also here happy to announce that Dr. Malati Prasad has been selected internationally as one of the 25 members for undergoing neurosonology in fetal medicine. So I congratulate on behalf of TNFOG, Dr. Malti. You great, keep going, Malti. So with this, I have the opportunity of welcoming all the faculties and the participants for this important series on renal disease. And I hope this entire program should be made into a video that can be seen by the the consultants or the students or the postgraduates, especially at whatever at the time of their leisure. So with this, I welcome everybody. And Malti, you can go ahead.
Yes,
Congrats, Malti.
Thank you, madam. I would like to thank all the faculties for joining in because we know it's very difficult to get eminent faculties like this. So all of you take use of this opportunity to learn from them. And today we are going to exclusively do only on renal anomalies because we're doing system-wise every month. So this month we're going to do renal anomalies, and we have eminent speakers like Dr. Bijoy, Dr. Sita, Dr. Renuka, and Dr. Sadipya, who are going to take us through an entire wholesome journey of the renal abnormality. So with this short introduction, I request Dr. Radhika to take over the chair.
I welcome all the faculties. Dr. Dhanlakshmi Madam, Dr. Tamil Selvi Naveen, Dr. Sri Priya, Dr. Renuka, Dr. Vijay, as well as Dr. Sitapal.
Thank you, ma'am. Thank you, Ramani ma'am. And thank you, Malati ma'am. Let's move on to the program. The first is the topic on renal cystic disease by Dr. Bijoy Balakrishnan sir. And our chairpersons are Dr. M.G. Dhanalakshmi ma'am and Dr. Tamil Shelvi Naveen. Now, I invite Dr. M.G. Dhanalakshmi ma'am, who is a professor and senior consultant, Department of Obs and Gynae from Sri Ramachandra Institute of Higher Education and Research, Chennai, undergraduate and postgraduate teacher since 1995. She's the executive committee member, OGSI 2023 and 24, and honorary treasurer, Chennai Menopause Society 2023 and 2025. She's also well known to all of us. And welcome, ma'am. And thank you, ma'am. And invite Dr. Tamil Shelvi Naveen, who is a consultant reproductive medicine specialist obstetrician gynecologist, EC member of Trichy OG Society and life member ISAR, IFS and PCOS Society. She has presented papers and posters in ASCOG, UFOXY, National, ISAR. Special interest on ultrasound minimal invasive procedures. Welcome, Dr. Tamil Shelvi, ma'am. Thank you. I invite Madam Dhanlakshmi ma'am.
Yeah, thanks. Yeah, thanks for the invitation, Ramni ma'am and Sampath ma'am. And I'm very honored to introduce Dr. Vijay Balakrishnan. His talks are well appreciated wherever he goes to give his talk. And he seems to be graduated from Karnataka University in 1999 and MS OG from Orissa, and head of the fetal medicine unit in CIMAR since 2007. And it was the first fetal medicine unit of Kerala, and organizing the Pericon series and SFM 2014. And he has to his credit 17 publications in index journals, and he's practicing fetal medicine for the past 13 years, well versed in all fetal medicine procedures, amniocentesis, CVS, PVS. Sir, we are waiting to hear from you, sir.
Thank you. I hope I'm audible. Let me just share my screen. Yes, good afternoon, everyone, and thank you so much for giving me this opportunity to be here. And I'm going to talk about renal cystic diseases. The next slide that I'm going to share is actually a very famous photograph, actually, that has come up on social media. I don't agree with the racial undertones of this picture, but I feel that this picture does explain certain things. If you look at this picture, I mean, most of us would agree that it's not true. Not all Asians look the same. There are a lot of us that differ from other Asians, and it's really not a good thing to say that all of us look the same. The same thing works for renal cystic diseases, because if you look at renal cystic diseases, you can see that there are three kidneys that I'm showing you here on the screen, and each of them have cysts, and not all of them are the same. And therefore, the purpose of this talk is basically to tell you that when you classify a renal cystic disease, it's important to understand what these disorders mean and what the clinical implications are. So, over the next 15 minutes, you're going to hear about renal cystic diseases, and then we're going to come back to this slide and try to analyze what each of these cysts are telling us. Now, when we look at kidneys, although we look at their location and the blood supply, there are two main things that we should look when we try to analyze each of the fetal kidneys. The first one being its echogenicity. We should look at the echogenicity of the kidney and compare it with the neighboring structures like the liver or spleen, and also look for what is called as corticomedullary differentiation. These two things are very critical while trying to analyze the kidneys. Now, corticomedullary differentiation basically means something that separates the cortex from the medulla. The cortex is more echogenic than the medulla because the cortex has got both the glomeruli and tubules, and their interface makes the cortex echogenic while the medulla appears hypoechoic. And that is one hallmark that you would find in all kidneys, where you would find that the outer cortex is echogenic and the inner medulla is going to appear hypoechoic, creating that corticomedullary differentiation. So these are the 2 points that you should look at in all kidneys. From there, when you see a cystic renal disease, the next important thing to do is to classify them. There are different classifications out there. I'm going to just concentrate on one, which is basically the ISWAG classification of renal cystic diseases, where type 1 would be ARPKD, that is autosomal recessive polycystic kidney disease. Type 2 would be MCDK, type 3 ADPKD, type 4 obstructive cystic dysplasia, type 5 where the cystic disorder of the kidney points towards a genetic disorder or aneuploidy, and lastly, an unexplained group of renal cystic disorders. Now, when I'm going to talk about them, we're going to talk about them one by one, and I'm not going to spend a lot of time on histology and all those things. I just want you to understand what is the ultrasound appearance and what the clinical implications are. The first one being ARPKD, or autosomal recessive polycystic kidney disease, in which you need two mutations to be present in a homozygous fashion at the PKHD1 location on chromosome 6p. It is not a very common disorder, it's quite rare. And when it presents itself, it's going to present itself as echogenicity inside the kidney. Now, this happens because you're going to get cystic dilatation of the collective tubules, which are going to be concentrated in the renal medulla, leading to a echogenicity and loss of CMD. So your cysts are going to be located in the medulla, creating a echogenic kidney. So one of the hallmarks of ARPKD is the size. The kidney is going to be extremely large, and the CMD is going to be lost because the medulla is going to be echogenic. The reniform shape is maintained. Both these kidneys are not going to be functional, and sometimes you can see cysts later on in pregnancy. So this is how it would look like: a very large kidney without amniotic fluid and loss of CMD, and this large bilaterally enlarged kidney is screaming out ARPKD. Now, because these kidneys are non-functional, you're not going to get good amniotic fluid around the fetus, and therefore you're going to get pulmonary hyperplasia. So a combination of bad kidneys with bad lungs means the outcomes are going to be poor, and most of the times we are going to counsel them for termination. The next kidney disease is an autosomal dominant polycystic kidney disease. Now, because it is autosomal dominant, you need just one mutation to be present on the PKD1 or PKD2 gene. And most of the times, this is a late onset disorder, which means that the kidneys may be perfectly normal during pregnancy and childhood and becomes abnormal during the third or the fifth decade of life. Less than 1% of them are going to be detected prenatally, and 10% of them could be de novo. That means the pathology may exhibit itself for the first time in the fetus, and the parents may be completely normal. Now, these abnormalities are going to be a slowly progressive abnormality which starts in one part of the nephron and spreads all over. And because it is slow and progressive, the kidneys are going to be functional. And what differentiates it from ARPKD is going to be the amniotic fluid, which can be normal in ADPKD. So on ultrasound, you're going to get a kidney that is slightly large, not as large as the kidneys in ARPKD. And another important point is the echogenicity, which is going to be confined to the cortex, creating an accentuation of the CMD, leading to exaggerated corticomedullary differentiation. So you're going to get cysts in the cortical region, creating a kidney like this. We're going to get an echogenic, enlarged kidney with presence of CMD, but it's going to be slightly bigger than your normal kidneys. And the amniotic fluid is going to be normal in most of these cases. Now, when you get a case with echogenic enlarged kidneys with maintained CMD, you should automatically look at the maternal kidneys and see if they are going to show signs of ADPKD as well. And when you do that, automatically your diagnosis becomes ADPKD, because at least 80 to 90% of these fetuses are going to have parents that are going to be affected. Now, outcomes are better than ARPKD because the kidneys are still functional. Amniotic fluid is present, therefore the lungs are going to be preserved. Yes, this disease is progressive, but we cannot predict at what point of time these kidneys are going to malfunction. Sometimes that might be the third decade or the fourth decade or even later. And therefore our counseling is going to be favorable, but guarded about the long-term effects of such a renal abnormality. And of course, it is imperative that we look at the siblings as well, because sometimes they might not have started to exhibit this pathology in their kidneys. The next group of abnormality is the multicystic dysplastic kidney. Now, this renal disease is completely different from the other two that we saw, because here the classic hallmark is this kidney no longer looks like a kidney. It's going to lose its reniform shape, and you're going to get a large collection of non-communicating cysts in the region of the renal fossa. So on ultrasound, you will see a large abdominal mass that is cystic. It will look like a collection of grapes, and there will be no connection between these cysts. And sometimes it may be present on top of a normal functioning duplex kidney, creating a confusion as to whether we are looking at an abnormal mass rather than an MCDK. Now, it's important to understand that the hallmark appearance of MCDK separates it out from other cystic renal diseases. As you can see in this clip, this does not look like a kidney at all. It looks like a large mass, multiple cysts with an echogenic parenchyma. Now, if it is unilateral, the association with aneuploidy is very low, and also the chances of good outcomes are better because you have a functioning normal contralateral kidney. But if it is non-isolated, which means there are other findings on ultrasound, then there is a 16.7% chance that there could be aneuploidy, and therefore invasive testing is warranted. But otherwise, MCDKs unilateral have got an excellent outcome. The next group of cystic renal disorders come in this category where it is secondary to an obstruction, which is called as obstructive cystic renal dysplasia. Now, these kidneys are going to have a variable appearance. They can be large or small, and they are always going to be echogenic. The CMD is going to be maintained. Sometimes you can get subcortical cysts as well. Now, the size of the kidney depends on the stage of obstruction that you're picking up this kidney at. If you're picking it up early, they would exhibit themselves as large kidneys with multiple communicating cysts. But if you pick them up late, they would exhibit themselves as small kidneys, shrunken kidneys that are non-functional. Now, here you can see a large echogenic kidney with multiple cysts that are communicating, which is present bilaterally, and immediately I'm going to look for signs of obstruction, and that sign of obstruction would be seen when you go down the urinary tract into the ureters or into the bladder, where you would see a classic keyhole appearance telling us that there is lower urinary tract obstruction, which leads to an abnormality in the kidneys, that is obstructive cystic renal dysplasia. Now, this was the easy part. this was the easy part because we know what these kidneys mean. We see a renal disease, we know this is exactly what we need to expect. But now the next group of renal disorders are where the problem arises. Because this is a group of renal disorders which points towards a genetic disorder or aneuploidy, and they have a lot of overlapping features, which makes it very difficult for us to make that diagnosis on ultrasound. The first among them is glomerular cystic kidney diseases. Now, glomerular cystic kidney diseases are characterized by cysts in the Bowman space. They're not very large. They are small cysts that are going to be present on the subcapsular space. The CMD of these kidneys are usually lost. The kidneys appear echogenic, and you would find small subcapsular cysts. Now, these kidneys are usually wrongly classified as MCDK. And when you wrongly classify them as MCDK, their implications can vary. Now, here the cysts are going to be present in the subcapsular region, and that's their hallmark. And this is how that kidney will look like. You have an echogenic kidney, loss of CMD, the reniform shape is maintained. It separates it from MCDK, and you would find these cysts are present in the subcapsular region. So when you find a kidney like this, it is important to understand that these are not MCDK kidneys. This is a glomerular cystic kidney disease, and the implications are huge. Because if you have a glomerular cystic kidney disease, you can have anything from genetic syndromes to trisomy 13, to follicular hypoplastic glomerular cystic disease, and so on. So when you find a kidney that looks like this, a detailed family history and pedigree analysis is very important. We have to look at the paternal kidneys, and we have to definitely test and go for amniotic fluid invasive testing and do a microarray and store the DNA for further investigation, and also put these fetuses on postnatal follow-up as well. The second group in this group of cystic renal disorders that points towards genetic disorders is medullary cystic kidney diseases. Now, medullary cystic kidney diseases, the cysts are going to be present at the corticomedullary junction. Around 10 to 20% of them are going to have a syndromic association, and these syndromes are usually going to be autosomal recessive. Now, the cysts are going to be present at the corticomedullary junction, and these kidneys can appear echogenic in the early gestation, and later on they can exhibit themselves as cysts in the medullary region with an echogenic cortex around it, as you can see here in the image. Now, when you have a medullary cystic kidney disease, a lot of syndromes should be running through your mind, but principally you should think of these four syndromes: Meckel-Gruber syndrome, Bardet-Biedl syndrome, Beckett-Wiedemann, and Joubert. Now, Meckel-Gruber is a syndrome that is diagnosed by the classical triad of an occipital encephalocele, bilateral polycystic kidneys, and post-axial polydactyly. So if you find an occipital encephalocele, which is now easily picked up in the first trimester, before you classify it as a simple neural tube defect, you have to look at the kidneys, and sometimes you would find the kidneys appear like two pieces of sponge sitting next to each other with numerous small cysts. And when you look closely, you would be able to see polydactyly as well. And when that triad is completed, you know you're looking at Meckel-Gruber's. Bardet-Biedl is again a combination of post-axial polydactyly with medullary cystic kidney disease, and a combination of endocrine problems like hypogonadism, obesity, and retinitis. On ultrasound, they would appear like this: as echogenic kidneys with the loss of CMD. The cysts in the medullary region would appear late, but the association here is going to be polyhydramnios with polydactyly. So if you have echogenic kidneys, polyhydramnios, and polydactyly, immediately your mind should be thinking along the lines of a Bardet-Biedl syndrome. Joubert syndrome is easy to diagnose because you have a classic posterior fossa anomaly, and because you see such a gross abnormality in the posterior fossa, which is basically an abnormal communication between the cisterna magna and the fourth ventricle, with a cleft that drives itself into the gap between the cerebral peduncles, giving you the classical molar tooth sign. We sometimes forget to look at the kidneys. But when you find such an abnormality in the brain, where you have a large cleft driving itself into the gap between the cerebral peduncles, it is important to look at the kidneys, because some of these kidneys are going to be echogenic with loss of CMD, pointing towards ciliopathies, disorders that are inherited in an autosomal recessive fashion. So medullary cystic kidney disease and glomerular cystic diseases are unique because they point towards some syndrome and they should not be brushed under the carpet as MCDKs. The last group of miscellaneous cysts would be cysts that are seen in the cortical region with normal CMD with a non-echogenic kidney. And these have got excellent outcomes. We don't need to worry about these cysts because the kidneys look normal, the CMD is maintained, and you just see a cyst in the cortical region. So your approach to cystic renal diseases has to be one, to look at the size, look at the echogenicity, look at the CMD, look at the location of these cysts, look at the entire fetal anatomy, and look at the amniotic fluid. This is how you would proceed when you try to make the diagnosis of what kind of cystic disease you're looking at. And when you find that they are non-isolated or point towards a particular syndrome, you should offer genetic testing in the form of microarray and store their DNA for further analysis. Now let's go back to our initial slide. This is the slide that I showed you right at the beginning. 3 different cysts. Now what do you think of these cysts? The first one on the left-hand side came referred to us as MCDK. The second one came referred to us as ARPKD. The third one came referred to us as again MCDK. But now from this lecture, you would realize that they are not all the same. The one on the left-hand side was yes MCDK because the reniform shape is lost and you're seeing large non-communicating cysts. The one in the center shows cysts in the medullary region is medullary cystic kidney disease, and therefore you should be worried about what? Meckel-Gruber's, Bardet-Biedl, Joubert, and all those syndromes. But on the right-hand side, the kidney that was classified as MCDK and was referred to us, and when we saw it, it is not looking like MCDK kidney. Why? Because the reniform shape is maintained. You're seeing cysts that are located in the subcapsular region, and you can see that the CMD is lost and it appears echogenic. So this is a glomerular cystic kidney disease, and we immediately advise the couple to do an invasive test with microarray. And on doing an invasive test with microarray, we found that this baby had, in fact, Down syndrome. And that's why it's important not to classify it as MCDK, because if it was classified as MCDK, unilateral MCDK kidneys do not require testing, but a glomerular cystic kidney disease is screaming to be tested. So it's important to understand that when we are looking at the kidney, we are only looking at a part of the bigger picture. We have to have a global approach to understand that not all cystic kidneys are the same. And they might be talking about a more serious underlying problem, and it is a sign that we shouldn't overlook. Thank you. Thank you so much for listening.
Thank you, Dr. Bijoy. That was really super fast lecture, which covered all the cystic kidney lesions. I know we could understand a bit, but then I would say when we get a report like this from our PT medicine consultant, we generally, as Madam Ramni Madam rightly said, we have to sit with them, find out how should I talk to the patient and the attender before blurting out anything without adequate background knowledge. I should be able to get from them what is the implications. Is it syndromic? Am I going to allow the pregnancy to be continued, or should think otherwise? So all this, generally we don't take a decision on our own. We generally group together neonatologist and PT medicine consultant and obstetrician involved with the patient, and then we take a group. So anyway, but it's nice to see good pictures and how you explain good videos. I love them. Thank you.
Thank you, Dr. Bijoy, for highlighting the fact to differentiate between glomerular cystic disease and medullary cystic disease and TCK. Because as I said, one of them requires a genetic testing, the other one does not require a genetic testing. Just leave them alone. Correct. So thank you very much for highlighting these points. It's very important when you have a polycystic kidney, when you identify the polycystic kidney.
I think we lost you, ma'am.
Lost her, yeah. No.
Sometimes you're not sure whether we are out of network or they are.
No. I think Malti is last, but anyway, it was a very crisp lecture by Dr. Bijoy, and Dana Madam has rightly pointed out here. See, if we get this report like this, I think it is always better to have a talk with the consultant. Then you reveal what should be give a message should be given to the patient. Because once when we tell that the child has got even a mild pelvic ileal dilatation, they will say that the child can have renal problems, so we don't want to have the child. But we have to tell, and especially in erythral wall and some of the lesions which are correctable postnatally, I think the counseling by both the fetal medical consultant and the general obstetrician is essential to have a safe outcome for the neonate.
Thank you.
There is one message.
Question to Dr. Bijoy.
Yes.
Yeah.
In case of unilateral MCDK, what are the changes the opposite normal kidney can undergo? Will there be a compensatory hypertrophy?
It is possible to get a compensatory hypertrophy, but usually most of the times these kidneys are normal, and MCDKs are usually unilateral. But sometimes we do see GCDK kidneys also exhibiting itself in a unilateral fashion. So whenever we find one kidney is abnormal, we should put the other kidney on close surveillance as well, maybe on a monthly basis or maybe once in 6 weeks to see that that kidney is maintaining its function. Because the moment the other kidney starts to get affected, then the prognosis changes as well. Yeah.
Can we classify ARPKD and autosomal ARPKD and recessive without CME, just with a scan? I think it's no.
No, see, although ARPKDs usually exhibit themselves as large kidneys, non-functional kidneys, but there are two varieties in which you can get normal amniotic fluid. That is the juvenile variety of ARPKD and the infantile variety of ARPKD, where you would get the same appearance that you would get in ADPKD as well. And sometimes you can get the CMD to be reversed, where the medulla is echogenic and the cortex is hypoechoic, and that can also happen in ARPKD. But usually it's a diagnosis that we can make clinically, and you don't have to wait for the genetic report to decide on the outcome of the pregnancy. But it is always good to do a genetic test because it allows us to select the fetus in the next pregnancy. Because sometimes these renal findings may become obvious only in the second trimester. So one, if you have the genetic diagnosis beforehand, you can do a CVS at around 11 to 12 weeks. Or if you have the facility, you can do even a PGD, select the embryo and transfer for these couples and avoid the birth of such infants. So a definite genetic testing for both. But yes, to a large extent, ultrasound will be able to tell you as to what kind of pathology you're looking at.
Glomerular cystic disease be bilateral or it can be unilateral? Is another question.
Both. It can be unilateral or bilateral. Again, depending on the stage at which you pick it up. So the kidney disease that I showed you at the end, which will belong to a Down syndrome baby, which was classified as MCDK, was unilateral. But it is possible that you can get it unilateral as well. But when it comes along with other syndromes, usually it is bilateral, and they appear as echogenic kidneys first. And as the gestation progresses, only these cysts become obvious. And most of the times it is a histopathological diagnosis rather than ultrasound diagnosis. But the main idea is to differentiate it from MCDKs. That's the main idea. You should not call all these cysts that you see in the kidneys as MCDK and say it's okay.
Thank you. Any more questions?
I would like to ask one to Vijay, if I may. Yeah, so this with bilateral so-called echogenic kidneys, the genetic testing that you would offer, you would limit it to microarray, or you would go on to go do a
exome. Okay, so my take on that is there was one paper in 2023 which looked at echogenic kidneys, which was a systematic review and meta-analysis of all echogenic kidneys. And 2 points are to be remembered. One is the renal size. The second one being the amniotic fluid, and also if there are other findings on ultrasound. So if you find echogenic kidneys that are of normal size, of normal amniotic fluid, then you're looking at 80% good outcomes. Now, of the 20% that are remaining, majority of them are going to be ADPKD. Majority of them are going to be ADPKD, of which again the outcomes are good. And then a few of them are going to be for the TNF1 alpha mutation, which can be picked up on your microarray. So if you find an echogenic kidney, what we normally do is we give them the option of microarray. We tell them that a microarray can be done to pick up the most common associated mutation with echogenic kidneys, although we would miss out on ADPKD because that will not come on your microarray. But we would also tell them that if this child is having ADPKD, usually the outcomes are going to be good. The infantile, neonatal, and even the adolescent outcomes are going to be good. And later on, only there might be a need for what do you say, renal transplant and things like that. So usually what we do is we do a microarray and store DNA. But on the other hand, if we do find something else, like recently we had a case in which we had echogenic kidneys, the amniotic fluid was normal, everything was normal, but the child had IUGR as well. So we tested, we did a whole exome, and we found that the child was carrying a mutation for a rare genetic disorder, which is inherited in an autosomal recessive fashion. So if it is non-isolated, with let it be anything, let it be FGR, short FL, anything. If it is non-isolated, we do the whole testing series, like we do array and exome. But otherwise, if everything else is normal, we offer a microarray.
Yeah, because sometimes the worry is that the amniotic fluid may be normal at 20 weeks scan
Yes.
when we are actually
Absolutely.
doing it. It might evolve into oligo later. But the point here, well taken, is that you must, you can get your answers with microarray. But if you're doing an exome, also please don't do a single exome, because that is only going to create problems and
Because we cannot identify the disorder on ultrasound. We
Yeah.
only know that there is an association with syndrome, and that's why I put on that list on GCDK. That list is huge. And you cannot just test just for ADPKD and say, or ARPKD and say that, okay, fine, this baby is going to be normal. We can't do that. So we always go for whole exome in these situations.
Yeah. Thank you.
Thank you, Dr. Bijoy.
Yes.
Over to the chairpersons, please. Thank you very much, Dr. Bijoy, for
Thank
joining.
you. Thank you.
Thank you. Tamil Shelvi ma'am, do you have any questions?
Yes, ma'am. Yes. Thank you, sir, for the excellent presentation. May I now introduce Dr. Selvapriya Saravanan, obstetrician and gynecologist, fertility and medicine center specialist.
She has not joined. She has not joined.
Oh, okay.
Go to the third talk.
So we move on to the next speaker. May I introduce now Dr. Sita Ramamurthy Pal, consultant fetal medicine and obstetrics in Apollo Multispecialty Hospital, Kolkata. And she had done her FICOG, FRCOG, and diploma in advanced obstetric ultrasound. And she's a peer reviewer of JOHI and Journal of Fetal.
Thank you. Thank you, Dr. Tamil Selvi, for the introduction. I wasn't ready for this. Just one second. Let me share my screen. Can you see my screen?
Yes, ma'am.
Just make it a slideshow. Okay. So after that wonderful talk, it's always, a bit this talk of after wonderful talk by Bijoy. So here I'm going to be talking about megacystis, which is the lower urinary tract. And as the name says, it is enlarged bladder. So at the outset, of course, I would like to thank Malati for the opportunity and the excellent TNFOG imaging series that you're conducting. I've tried to attend most of it, but all of them have been brilliant. So thank you, and thank you for this opportunity, and all my greetings to the TNFOG members, especially Ramani Madam and Sampath Madam. She's not here. So, so basically, we'll be going about how do we define megacystis in different trimesters, the causes that can be, and that depending on that, what the approach should be, practical approach, and what are the management options we have at this stage of our at this stage or whatever gestation that has been diagnosed. So when we talk about blood or whenever basically the physiology is that fetal urinary production begins at around 10 weeks. So normally when you do your first trimester scan, as you take a sweep along the fetus from head to toe, you should be able to see the bladder with the two umbilical arteries beside it, and it appears as an anechoic structure within the fetal pelvis. Now, here is something that you have to wait, because if you can't see it, you should wait for the bladder to fill, because sometimes, the bladder is not adequately filled, so you might have to wait and make sure that the bladder is there. And a rough estimate that would be to measure the bladder sagittal length is the gestational age of the fetus in weeks -5 will give you the normal fetal bladder for that gestational age. So that is a rough estimate as we have for our MCA PIs and stuff. Now, what is megacystis? It's basically an abnormally distended bladder. And of course, as Dr. Bijoy said, it is important to distinguish what is causing what. So this is primarily a lower pathology, lower urinary tract pathology, which is causing changes in the upper urinary tract as it evolves into severe conditions. So
it is basically a heterogeneous group of congenital anomalies, and we can have either a functional or a mechanical bladder outlet obstruction, which is usually the case. And this happens in about 3 out of 10,000 pregnancies, but there is a wide spectrum of severity, as we will see. And because of its varied etiology and uncertain evolution as how it's going to be, unpredictability rather, as how the fetus is going to be after in the postnatal life and later on, it is a major challenge. So it's easy to diagnose. It is quite challenging in terms of its counseling and management as and when we pick up in different trimesters of pregnancy. So what is the definition? It's basically, if you can see in the first trimester, it is very classical. These work definitions are there that the longitudinal bladder diameter should be more than 7 millimeter. If it is more than 7 millimeters classified, it is defined as megacystis. And it can be anything between 7 to 12 with like ventriculomegaly. This is also sort of not classified, but we always tend to say that if it's 7 to 12, it's sort of a moderate, but more than 15 will indicate more of an obstructive pathology, especially a lower urinary tract obstruction. Anything between 7 to 12 is sometimes, or more than not often, is a transient finding. So you have to watch them, of course, counsel them accordingly, as we will say, because a lot of them can resolve, and that gives a good prognosis. So this is how it would be in the first trimester. In the second trimester, however, it is very heterogeneous. There is no clear-cut definitions or standardized measurement cutoffs. It is subjectively seen that, of course, it is very obvious to the eye when there's an enlarged bladder. But what is important is that it fails to void over a period of time. And it continues over, the entire ultrasonography examination, or you may have to call her back later after half an hour to see if this is persistently enlarged or not. And sometimes we also say that the fetal bladder, if it is actually reaching up to the umbilical cord insertion, at the level of the cord insertion, then, this would classify as a megacystis in the second trimester. And as I said earlier, there is no standardized measurement cutoffs which defines the degree of bladder enlargement in the second or third trimester. And obviously, they are not available as of now. So what, this is the group of Villarado and especially Fontanella. They have done a lot of work. In fact, this was a thesis of megacystis and the Luto. And they have actually come up with nomograms for fetal urinary bladder between 15 to 35 weeks, where they have actually taken 3D and 4D sweeps of the urinary bladder, and they have calculated the volume by sono-ABC and vocal techniques. And then they've also measured the longitudinal bladder diameter, and with all put together, they have come up with reference curves, which can be looked up in this reference that I've given. They're not very practical to use, of course, because it is not feasible to be done by all, but there is something that we have for nomograms in the second trimester. Now, what are the causes? As we would say, most common is the obstructive causes, which is the lower urinary tract obstruction. So megacystis means, lower urinary. Usually, it goes with lower urinary tract obstruction, which is often termed as Luto. But there can be non-obstructive causes, which are usually sometimes chromosomal abnormalities like the trisomy 13, 18, miscellaneous genetic syndrome, something associated with single gene disorders like BCN1, BCN2 genes, sometimes associated with development and anomalies like anorectal malformations and cloacal malformations, especially in the fetus, as Dr. Ramani Madam was saying. And of course, with some sort of, smooth muscle disorder, like megacystis, microcolon, intestinal hypoperistalsis, where all of these have problems and cause lower urinary, megacystis. But obviously, whenever we see megacystis, or, as always, you have to look for other anomalies present in the fetus and then decide whether it is isolated or could be because of other genetic problems or other anomalies. So as I said, the main cause is lower urinary tract obstruction, and lower urinary tract obstruction is usually because of a posterior urethral valves in a male fetus. But of course, it can be because of other severe conditions which are incompatible with life, like urethral atresia, megalourethra, cloacal malformation sometimes, or prolapsing uretrocele, where you can see sometimes daughter cysts coming there. But you have a typical classical triad, in this posterior urethral valves, where we see a megacystis, a keyhole sign, and then if you see it later, it could have back pressure changes on the kidney causing hydronephrosis. So this will be a classical triad of PUV or Luto. Now, what happens if it is left untreated? as would be logical, that the bladder flow obstruction is there. So progressively the bladder dilates, the bladder wall thickens. This causes back pressure changes, as we saw obstructive renal dysplasia, where the renal parenchyma gets compressed, and then obviously there is a reduced amniotic fluid production, which causes severe oligo, even anhydramnios to that extent, and these causing like lung hypoplasia and fetal and perinatal mortality, especially if the oligohydramnios is severe in the second, third trimester. It could go up to almost 60 to 80%. And the risk of developing end-stage renal disease in these fetuses is almost up to the range of 30%, which is actually not very predictable antenatally. That is the worry here, that whatever we do, whatever we see, even if the LICA volume is normal, are we actually able to predict whether these kidneys will actually function normally later on? And yes, they've also seen that renal hypodysplasia can be secondary to Luto or single gene mutations and nonsense mutations, like in some genes like BCN2 gene, as some have described. So because of the high rate of termination of pregnancy, the minute you see if there is oligohydramnios, or even if there is lack of availability of treatment in whichever centers they are diagnosed, because of the varying degrees of severity of obstruction that we see are different, and the possibility we're not able to predict what ultimately will happen to this fetus in the neonatal period, it is difficult to predict life expectancy in Luto, because we don't know what the absolute outcome would be later on in life. But what is the main differentials? The main differentials from urethral atresia, because Luto, because of posterior urethral valves, is still amenable to treatment if properly selected, as we will see. But urethral atresia is something is not compatible with life, and there have been certain findings which have been suggested that could be differentiated from urethral atresia, like if the NT is most of the 95th centile, presence of umbilical cord cysts is debatable, but yes, sometimes they can be associated. But also they have said that the shape of the bladder sometimes can cause, it's typically elongated in posterior urethral valves and sometimes can be circular. But these are some of the, may not be obviously classical of each, but yes, there can be some ways of differentiating. Now, this is from our own, Dr. Suresh sir has been part of this study for differentiating between posterior urethral valves and urethral atresia, where they have come up with Z scores of the fetal bladder size, and they have come up with normograms for the fetal urinary bladder diameter and volume between the 15 and 35 weeks of gestation. And they found that fetuses with posterior urethral valves had a significantly lower Z scores compared to those with the urethral atresia. And here they have said it was quite sensitive for about 74% and a specificity of 86% when you considered Z-scores of less than 5.2. They could predict quite well if it was actually posterior urethral valves or urethral atresia. So what would be your approach? As I said, it's very easy to diagnose. You have your first trimester scan. You see on the your first trimester screening for nuchal screening, where you see the bladder is dilated. Now, if it is less than 12 millimeter, the chances of obstruction are less, but there are increased chances of chromosomal defects. So you have to have a complete detailed evaluation of the fetus from head to toe, as a first trimester anomaly scan. And here it is more important to offer genetic testing as a chromosomal microarray, especially if there are associated anomalies. You could offer whole exome sequencing, but it is important to note that if the genetic testing is normal, when the bladder diameter is still within 12 millimeters, there is a chance of spontaneous resolution in 90% of cases. So this is something that you need to tell them. And of course, we cannot say that provided this is, genetically normal. So that is very important. You cannot just say without doing the testing that it would resolve. But if that is normal, then it would resolve in almost 85 to 90% of cases. So these are some cases which we saw. Initially, this was a lady in IVF pregnancy. She had also a suspected cleft lip, and of course, she ended with termination. And this was a lady later, around 12 weeks. As you can see, the bladder diameter was 12 millimeter. This was fine. As always, they never tend to follow up. But, from what we know, possibly this resolved and she had a normal outcome. But that is the minimum that we got to see. This is a lady who came at around 11 weeks, where the bladder diameter was almost 17 millimeter. We did tell them, counsel them accordingly, but later on she came back at 18 weeks, 4 days, when there was an IUD, obviously with severe oligohydramnios. So it has its, nature takes its own course. Sometimes it's better to just wait and watch what happens, but it is important to counsel them and document that what are the implications of this severe megacystis at this early gestation. So regarding all this, groups, especially the Fontanella group, they have also come up with a proposed clinical score as to whether you can sort of just make out whether it is moderate or severe. And they have sort of given points whether it is severe megacystis, take the mean of both the urethral diameters, whether there is presence of oligo and anhydramnios, if it's a female, if it's a male sex, or if the referral, or if it's diagnosed before 28 weeks, they score it up and they have said that if anything more than 9.5, it could be severe luto. So this is obviously not usually practiced. We tend to look at the ultrasound because more the ultrasound pictures are very, they talk for themselves. But again, important to see that when there is oligo or anhydramnios, it is sometimes difficult to scan the fetus entirely and, to rule out other anomalies as well. So that becomes a challenge sometimes, but it is important to make sure that it is isolated. So what are the predictors of outcome? As I said earlier, that if the bladder diameter is less than 12 millimeter and it resolves before 23 weeks, this has been suggested that this could be these fetuses will tend to have a good outcome later on. But if there is oligohydramnios less than 20 weeks, there's presence of other anomalies, which you're sure there isn't, as I said, because it's a challenge to look when there is severe oligohydramnios, then obviously the outcomes are bad. But these are other predictors which are not sort of very, strong as these, like the presence of umbilical cord cyst, amniotic fluid volume, because even in the presence of normal renal volume or normal amniotic fluid, you cannot predict that this baby is going to be fine postnatally. And of course, the appearances of renal cortex, as we have seen earlier, whether the obstructive dysplasia has the renal the corticomedullary differentiation has gone or not. And of course, with biomarkers, which will tell exactly when we can intervene. So we have fetal urinary biomarkers, which are important. But whatever it is, the risk of renal replacement therapy cannot be predicted. And that is something we have to explain to the patients that whatever we do, this is something which we cannot predict with accuracy. So generally, when this happens, and if they are amenable to treatment, we would do a fetal urinary analysis. And this would be the normal urine parameters for fetal urine, that is a sodium less than 100, calcium less than 90. But more importantly, the beta-2 macroglobulin, where the levels tend to increase when the tubular reabsorption is affected. So anything less than 6 is normal, and anything more than 9 we would consider as severe. And of course, this is important, where when we do one sample is not enough. Usually it is 2 to 3 samples are collected over an interval of 48 hours. And if all 3 samples show good parameters, then obviously this means that this fetus is possible for intervention. Now, again, some of these cases which have been predicted typically in the second trimester, where you can see the bladder keyhole sign, typically with a dilated proximal urethra, and scanty-like or almost at 21 weeks, obviously, with very, very poor prognosis, and most of them end up with termination. This lady, though, when she came at 22 weeks, I couldn't see anything. It was just this huge mass in the abdomen. Couldn't make out what it was. The fetus stuck to one side. The entire thing was the megacystis, absolutely no liquor. I mean, these are sad scenarios which, they come so late, but unfortunately, the outcome is going to be poor here. And this is another case where the bladder, there was a bit of liquor, so possibly, this could have been amenable to treatment, but earlier. But here, when she came to us, she was already 34, 35 weeks. And here it is just that we need to monitor them postnatally and give the prognosis that whatever she might need postnatal intervention. This was the case we saw recently. Again, at 21 weeks, typically, the keyhole sign was here. But she also had, obstructive changes in kidney, where there was dilatation, hydronephrosis. There was bilateral talipus. We, couldn't make, obviously it could be positional or it could be syndromic, but yes, we did tell them to have a DNA storage. So whenever these pregnancies get terminated, it is important to have at least DNA storage, though most of them are not usually associated with pure luto, pure posterior urethral valves. It is not usually associated with genetic conditions, but it is when they are terminating a fetus, simple DNA storage will not do any harm. So the management options when we come to this is vesicocentesis. We drain the distended bladder. Of course, the vesicoamniotic shunt placement, which has its place, and furthermore, a more Definitive treatment would be a cystoscopy and fulguration. And of course, in our set of populations, most of the cases end up with termination. But whatever you do, it is important to realize that's that very fine line that we demarcate, that we need to avoid unnecessary treatments in cases unlikely to benefit due to severity of disease, as well as to those who are likely to survive and have a good prognosis with conservative management. So you should not be intervening unnecessarily and also not doing treatments and where there is not going to be any benefit. And that is something very difficult to predict and difficult to select as well. So what about vesicoamniotic shunting? It's basically, as the word, as the name would suggest, it's a shunt placed in the bladder. So it's a temporary this to enable the continuous drainage into the amniotic cavity and bypass the blockage. So etiology has to be luto. It has, so that is the problem where here the selection of cases become very important. Though the shunt increases the chances of perinatal survival, it is unlikely to have a major impact on long-term renal health. And this is what the landmark Pluto trial showed in 2013, where it was an open randomized trial evaluating the effectiveness of shunting compared to conservative management. And they had to prematurely end it because the recruitment was low. But it did demonstrate some improvement in 28 days and 1 year and 2 years compared to those with conservative management. But their overall bottom line was that overall prognosis was not very good. So when you do VAS, we don't do it in our setup here, but I'm sure there are the Joy and in their settings they do it regularly. Done as an OPD procedure, and we have two shunts available: the Harrison shunt and the other shunt here between 20 to 27 weeks. Though there has been recent studies where they have tried to do it earlier in gestation. The logic behind that is when the Leica volume is good, you're able to do it properly. The procedure is easier, and it has a better prognosis for these babies, rather than when you have to wait till the oligohydramnios or anhydramnios is already set in, where you might have to, the procedure becomes difficult. You have to amnio infuse and do the procedure. So, but generally done between 20 and 27 weeks. It's done with fetal anesthesia. With oligohydramnios, amnio infusion is done with ringer lactate, and the shunt is actually positioned in the anterior abdominal wall. And because of that, it is quite likely that the baby can, pull out the shunt with its hands. There can be risks of preterm birth and PPROM and even shunt expulsion. So these are the two stents that are used. And I'm not going into the details of the procedure, but as you would see, and the problem is nowadays that these shunts are not available. In the West, they use something called a somatic shunt, and a lot of studies have showed brilliant results, especially the one study that showed in the earlier trimesters, they have used the somatic shunt and shown good results as that. So here, once the shunt is in place, this is how it would look. And you have to do our follow-up scans after 1 to 2 and 4 weeks, and then regularly. But sometimes if there is a shunt migration, it can happen, and you might have to, do a zygocentesis again. But the shunt is usually left in situ until you have further definitive treatment postnatally or, other options. So this is another study which was done by Renal et al., and they have actually classified the luto into stage 1, stage 2, and stage 3. And they have said where the selection becomes important and where fetal intervention becomes indicated and possibly beneficial. So they have said that when the amniotic fluid is normal, the fetal kidneys the echogenicity is normal, there is no renal dysplasia, and the urine biochemistry is favorable, that is after 3 samples, then usually it's not indicated. You can just leave them alone and follow them up. But if it is hyperechogenic and again, the renal parameters are favorable with oligohydramnios, this is stage 2, where you can still preserve the renal function and where your fetal intervention would be indicated to further to stop the further renal impairment and subsequent pulmonary hyperplasia. But if there is severe anhydramnios, there is renal dysplasia, the fetal urinary parameters are not favorable, that is something which we can't really help much, and we might have to tell them to, whichever stage of pregnancy as to discontinue the pregnancy. So now the next option is the cystoscopy laser ablation, where again, we're here is actually going through the cystoscope, through a cystoscope, you identify the posterior arterial valve, so it becomes diagnostic as well as therapeutic, and you fulgurate the valve with a diode laser through the cystoscope. So obviously it is more physiological, it avoids repeated surgeries, but there are some rare complications of like the zygoectogenous fistula, and of course the risk of preterm birth and premature rupture of membranes. And these were this was a systematic review again 2011, where they compared fetal cystoscopy and VAS, and they said the cystoscopy laser valve ablation improved the perinatal survival compared with no treatment, but no differences were observed between cystoscopy and valve placement. And this was a recent study in 2020 where they found that there was no difference found between the cystoscopy and VAS regarding survival, long-term kidney function, or urological outcome. And despite the optimistic reports, it lacks reproducibility because sometimes it is very difficult to maneuver the cystoscope through the dilated urethra and go through that. But I'm sure it is good in expert hands. Now, again, the Fontanella group has come up with this algorithm, which I've taken from their publication here, where they have divided into early and late. And they have said that if you have an early megacystis, you do a detailed examination and do a QF-PCR, that is genetic testing. And if there are associated anomalies, you decide accordingly. But if it's absence, if it is less than 12, you repeat the scan. And if it resolves before 23 weeks, is good. But if it doesn't, you have to follow them up. But if it's more, then you have to consider, and they have subsequently given that in their next chart. But if it's late megacystis, you have to, again, typically you have to do consider microarray testing, looking for other deletion syndromes. And if it is more than 22 millimeters, and if the score is 9.5, you can sort of do for intervention. So here they have, again, if it's moderate luto, you can sort of have the three options. If you are doing an expectant management, do a weekly ultrasounds, or you can do fetal interventions, and of course estimate the postnatal renal function in their way by zygosynthesis, and then you have to deliver them as a tertiary care center. This is a sort of a guideline they have given, but it obviously depends on the center you're working, the facilities you have for intervention, and whether the patients can afford all this. And this is overall telling you what needs to be done for what. This is all available on the net, but just have put it here. So basically the take home messages is, a simple megacystis can be just simple, but you have to rule out complex cases. And if it is less than 12 millimeter, it would resolve in 80 to 90% of cases. You have to follow them up. And the cutoff for uneventful resolution is around 23 weeks. In late megacystis, you can use your 5 ultrasound parameters and then look at the score. But whatever it is, this is the Kakut Obstructive Uropathy work group. They have come with recommendations regarding how do you diagnose, how do you differentiate, what are the adverse outcome features. But whatever it is, the fetuses with prenatal megacystis, they need to be referred to a tertiary obstetric center. Sorry about that. And proper selection of cases is very, very important for intervention. And even if prenatal treatment is indicated and done, parents must be informed about the potential benefits for postnatal survival. And they also should be made aware of the risk of postnatal kidney failure despite fetal intervention. Thank you so much for your patience here.
Thank you, ma'am.
Sita, I think it was fantastic. Beautiful talk on megacystis.
Thank you so much.
For the benefit of viewers, can you tell us the cutoff for the megacystis in the first, second, and third trimester?
Yeah, so it's anything more than 7 in the first trimester is there, but 7 to 12, we tend to believe that it is more because of genetic chromosomal abnormality. So you have to sort of go ahead and do genetic testing. But anything more than 15 would suggest an obstructive pathology. In the second trimester, as I said, it's very variable. There is no cutoff. So a persistently filled bladder, or fetal bladder, persistently enlarged bladder, or a bladder coming up to the level of cord insertion is what they have mentioned. But we don't have standard values or
Because sometimes we do find, even in the third trimester, we find a huge distended bladder.
Yeah. So it's important to wait for it to avoid, Like in the first trimester, we wait for it to fill. In the second and third trimester, it is important for it to void. So we usually
other doctors that we found a distended bladder, just keep a watch on these.
Usually in the second and third trimester, the lico volume is normal. Everything else is normal. This is just a voiding, late voiding feature, isn't it? If you see that, one look at the fetus, you will know what is happening there, isn't it?
Sita, I have a question for you.
Yes, madam.
In the first trimester at 13 weeks, when you do an anti-scan, if you find a megacystis almost filling the entire pelvis of the baby, okay, then what will be your stand, whether you terminate the pregnancy?
So as I said, madam, if it's you measure the longitudinal bladder diameter, and if it's anything more than 15, then the prognosis becomes quite poor. So because it is a very severe obstruction and presenting so early in gestation, it's not going to be. It is definitely invariably going to lead to anhydramnios in the second trimester and possibly death. So those sort of
Yes.
severe, more than 15, we would sort of say that, the prognosis seems very bad. But anything less than that, around 7 to 12, as I said, less than 12 or even 13, 14, we could say that, there is a chance. We have to evaluate it and then scan them again after 2 to 3 weeks to see what's happening.
We waited for
We
1
have the
week.
results as well.
Then the diameter of the bladder was almost 2 centimeters. So then nothing else, we had to go in for a termination. And is it worth doing some chromosomal study or microarray study for these patients?
Yes,
So if you're going, definitely always an antenatal testing is better. So at 12 weeks we do offer a CBS for them. But if the prognosis is poor, then we always advise for a DNA storage later on once they terminate the pregnancy, because you never know what these fetuses are to have. Though they are very rare, but it is always better to have this information in hand before they embark on the next pregnancy.
Okay, thank you. Thank you so much.
As
I think it
Dr.
was a
Sita
very,
said,
very
how
clear
do you
cut lecture.
Dr. Sita, a question. Suppose we find a typical megacystic bladder with urinary ascites. So
Yeah.
how is the prognosis going to be? Because very often we find that there's an increasing ascites.
And I didn't cover that. The bladder ruptures sometimes, and there's yeah. So again, it all depends on what the changes are there in the kidney, what is happening there. Yeah. And if that has already happened, then the prognosis is still not very good.
Surprisingly, I think vesica-amniotic shunt procedure we used to do it till about 3 years back, and the shunt is not available.
Not available, yeah. That's the thing.
Actually, we had put a shunt for one of our patients, and the baby delivered holding the shunt in the hand.
Typically, the babies tend to pull it off. Something, as Dr. Sudeshwar says, it's something for them to play with in the fetus, in the utero.
So when we delivered, the baby had the shunt in hand. So the obstetrician took a picture and sent it to me. So shunt, I think dislodging is very, very common.
Very common.
It's not available now.
Because we put them around at 26 weeks and you have a long way to go after that, isn't it?
That's right.
Yeah.
Questions?
If you have anything to add, Malati, you can please.
Nothing much, ma'am. We only wanted to ask about urinary ascites, because we had a similar case about 2-3 weeks back. Actually, the first time she presented only with ascites with normal looking bladder.
Right.
And 2 weeks back, when we told her to come back for a review, we found the typical distended bladder, not even a distant bladder, maybe slightly distant bladder with a keyhole appearance. And changes in the kidney, along with the increasing urinary ascites. So at around 20 or 22 weeks of gestation, we offered termination, counseling, continuation. She wanted to terminate the pregnancy. We asked for fetal postmortem to look at the it was a male baby, XY. So most probably
yeah.
Any comments from the chairpersons, please? Dr. Dhanlakshmi and Dr. Tamchal.
This post-urethral valve obstruction is what we generally encounter. Usually our pediatric urologist takes care of the counseling, etc. So, but if it is UTD 1, 2, 3 reported, UTD 1, if they don't have time to go and consult a pediatric urologist, I counsel them like nothing to worry, then you can follow it up with the next scan. But if it is anything more than 2 and 3, I better involve a pediatric urologist. We never know what they are in store for.
Yeah.
So, only that much. The rest of the things, usually it is a combined counseling. We don't do it alone.
Thank you, ma'am.
Tamchal, you want to add something?
It's an excellent presentation, ma'am.
Thank you.
From the experts.
No.
Thank you, Dr. Sita. Thank you very much for joining.
Thank you. No, it's my pleasure and honor.
Yeah.
And congratulations, Malati. Where are you going? Where are you off to for your neurosonography?
Barcelona. I'm going to Barcelona.
Barcelona. Oh, that's nice. So,
I always had a lot of passion for fetal neuro, so I just applied and got it. Let's see.
Great.
Hope everything goes in the right way.
Yeah.
God willing. Thank you.
Okay.
Welcome, Dr. Renuka. Dr. Renuka.
Hi, ma'am.
Well,
good evening.
We're meeting for the first time on screen. We've spoken on the phone.
I don't know if I'm visible.
Very different way of putting our CV. No, first time I'm seeing nicely classified. I'm sure our presentation also will be like this. She's graduated from graduated from Meenakshi and then did her masters from Kilpauk and then did a fellowship in Bangalore, and she's affiliated to almost all the known societies. And she had started her career probably as a general OBGYN and then shifted to fetal medicine later. And she's right now maybe heading the Teni Fetal Medicine Center till date, and Rio General Children Hospital. We are looking forward to your presentation, Dr. Renuka. I'm sure it's going to be as interesting as your CV.
Am I visible, ma'am? Am I visible, ma'am? Can I?
Yeah, you are visible
Yes,
and
ma'am,
audible.
yes.
Go ahead, Dr. Renuka.
Okay, ma'am. Okay.
Please make it full screen, ma'am. Yes, thank you.
Before starting, I would like to thank TNFOG and Dr. Malati ma'am and her team for giving me this opportunity. The topic given to me was renal anomalies, and most of it is almost covered. I'll be just touching upon few common anomalies which is missed till now. Why are we worried about renal anomalies? As Ramani ma'am rightly pointed out, it is as common as a CVS and a CNS abnormality, and it is most often a part of an aneuploidy or any syndromes. So once the understanding renal abnormality is possible with a little knowledge of embryology. Usually we have three kidneys. It is a pronephron, mesonephron, and metanephron. The third part, that is the metanephrotic kidneys, is the functional kidney in us. And for this, the mesonephric duct forms the ureteric bud. This process is called induction. And the rest of the kidneys is formed from the mesonephric blastoma. Having said this, lots of processes are involved in formation of the kidney, and it is once the kidney is formed in this region, it has to ascend and rotate at the same time. So any problem in any of the steps can result in renal abnormalities. So this is just to sum up that. It can be either abnormalities in the number, as in renal agenesis, unilateral, bilateral, abnormalities on the ascent, resulting in ectopic kidneys, harsho kidneys, or cross-renal ectopia. So in this talk, I'll be dealing about renal agenesis and ectopic kidneys. Bijoy sir has already covered most of the structures related to the volume and structures, and likewise, I'll touch upon the collecting system, urethrocoel. Okay, coming to renal agenesis. Typically, when you have a case, how do you come to a diagnosis of renal agenesis? Either during a routine scan or for a second referral, the first thing said is empty renal fossa. The picture in the left-hand side shows normal renal scan, but the next two pictures are to show the bilateral renal agenesis. How to pick up a renal agenesis? If it is going to be bilateral and you are seeing her after 16 weeks, definitely you can make the diagnosis, because always kidney abnormalities are associated with abnormalities of the fluid and bladder. So any case of renal abnormality, the first thing you'll see for us, assess the kidney, assess the bladder, assess the fluid, and assess the ureter. So in case of a bilateral renal agenesis, obviously you are not going to see the kidneys, but sometimes the intestine and the adrenal may mimic the kidney. In such case, non-visualization of the bladder and anhydramnios will give a clue to diagnosis of renal agenesis. Likewise, with the advent of color Doppler, it is even more easier to appreciate the absence of renal vessels in the presence of anhydramnios. So it will help us aid in the diagnosis of absent kidneys. How to differentiate between a kidney and an adrenals? In the kidney, the medulla is always hypoechogenic when compared to the cortex. But in case of a medulla, the medullary medulla is going to be, the adrenal medulla is going to be hyperechogenic. That is, it's going to appear bright. This will help us not miss on renal agenesis. Okay, then is it associated with some other thing? Obviously, the association with chromosomal abnormality is very minimal. It's only in 1 or 2% of the cases. So most of the cases of renal agenesis is going to be a sporadic case. But sometimes syndromic associations like Fraser syndrome, Bacterial mucus, and N number, there are about 40 syndromic association. So once you diagnose an empty renal fossa and come to a diagnosis of renal agenesis, then the next thing will be to look for all other system and all the other anatomy, so as to come to a conclusion if it is sporadic or is it a part of a syndromic association. After ruling it out, if you think it is a part of a syndromic, or if you find some other markers or abnormality which will suggest to a trisomy, then you advise them to go ahead with the invasive testing. We'll start with the karyotyping, and if you have anything in mind, you can do a DNA storage, and we can work it, take it up further after the karyotypic report. And when coming to the prognosis and counseling about the prognosis, in case of bilateral renal agenesis, apart from non-functioning kidney, there is no lighter. So even the lungs are not going to develop. So absolutely, this is a lethal condition. And if you find a bilateral absent kidney, we can very well counsel them for a termination. And coming to the next question, which the patient puts, what is the chance of recurrence? Will this occur in the next pregnancy? Sporadic, very negligible. But if it is going to be a part of some syndrome, it depends if it is autosomal recessive, or it depends upon the nature of the syndrome. And if you find any renal abnormality, it is always advisable to ask for the parents' ultrasound abdomen to rule out any renal abnormality in the parents, because in 10 to 15% of most of the renal abnormalities, there will be an associated abnormality in the parents. If there is no abnormality, then the recurrence risk is very negligible. But if you see an abnormality in any one of the parents, then the risk increases by 10 to 15%. It applies for almost most of the renal diseases. Okay. Supposing a patient is referred to you saying that one side I can't find the kidney, what will be the differential diagnosis? It can be 3 things. 1, that side kidney is not at all formed and it is absent. Or the second differential can be the kidneys are formed, but it has not ascended to its position. Or third one, the kidneys are formed, but they are present in opposite side or some other. The last 2 will be a fusion or ectopic kidney. The first thing will be a unilateral renal agenesis. We all know that one kidney is sufficient for a human being to function all his life. So if you come across a case of unilateral renal agenesis, like I said previously, we have to look out for all other, to rule out any chromosomal abnormality or a syndromic disease. Once you are through a thorough ultrasound examination, you have ruled out trisomy or a syndromic approach, how to go further. Next thing, if it is unilateral, it is not mandatory to offer them an invasive testing. You can just follow them up because they are at an increased risk for obstructive, like vesico-ureteric reflex, infections. So you just follow them with serial monitoring from 28 weeks, every 4 week scans, and delivery and other things are usual parameters. And you can very well counsel them. The outcome of this pregnancy will be good. Only thing is they need to have a postnatal follow-up, even to look for infections or any calculus. And they should be a little cautious and avoid any sports or things which can cause damage to that side kidneys. And immediate postnatal period, it is also mandatory to rule out any other genital abnormalities because sometimes it cannot be picked up in the antenatal ultrasounds. Likewise, the recurrence rate of fusion as well as unilateral renal agenesis is going to be the same. They are less than 3%, and that's it. Now let's move on to the next anomaly, that is anomaly of the fusion. Horseshoe kidney has to be given a little weightage because this is a relatively common condition of all the renal abnormalities. And how to identify a horseshoe kidney in a scan? The first, you will get a when in doing a routine scan, you will get a doubt that these two kidneys seems to be a little off their position. But sometimes you may see that they may look like they are in the proper position. But if you give a proper look at the kidney, then you will find that they are little oriented this way, that way. And the lower margin of the kidney cannot be well made out in most of the cases. And you can sometimes demonstrate, but the crux of diagnosing a horseshoe kidney is always demonstrating a isthmus, that is the connection between these two right and the left kidney. But this is not always possible. It is only the gut feeling which sometimes helps in the diagnosis of a horseshoe kidney, where, as I said, the lower pole of the kidney may not be that visible. And when you see the pelvic orientation, instead of they being at perpendicular like this, they'll be a little to the anterior. It is little rotated to the anterior because always horseshoe fusion abnormality is associated with a little malrotation. Cho et al. Has proposed renal pelvic angle in the diagnosis as a tool to diagnose horseshoe kidneys, in which, as you can see, when in a normally placed kidney, the renal pelvis, when you measure the renal pelvic angle, that is angle between this pelvis and then this pelvis, this will usually be more than 172 in the second trimester and more than 161 in the third trimester. But in the case of horseshoe kidney, since it is a little malrotated, the renal pelvis angle appears to be reduced, and it is usually less than 116 and 110, but we take a cutoff of 140, which may help in identifying a horseshoe kidney. We all know that horseshoe kidney is associated in about 30% of cases Turner syndrome and 20% of cases with trisomy 18. And syndromic association is also seen very common with horseshoe kidney. So once you identify a horseshoe kidney, it is mandatory to ask for a invasive testing. And you also have to, like I said previously, please look for other abnormalities or other markers. Now you have arrived at a diagnosis, given them the invasive, and invasive testing has come out to be normal. Then how do you follow them up? You do every 4 weeks scan, because like any other rotational or fusional abnormality, they are associated with vesico-ureteric reflex, and these baby can develop hydronephrosis at a later gestation. So this will help us identify, pick it up early, and decide on further treatment and timing of delivery. Prognosis of a horseshoe kidney as such is very good if we have ruled out chromosomal abnormalities. Coming to recurrence risk, if it is a isolated or if it is a part of Turner syndrome, there is no increased risk. But if it is going to be a part of trisomy 18, then it has a risk of about 1% extra from the baseline population. The next form of ascent abnormality is crossed renal ectopia. This means that the kidney, instead of being right kidney being in the right side, it will be in the left side or vice versa. And there are so many forms, so many types of crossed renal ectopia. And these two kidney can be fused or they can lie nearby isolated. If you find how to come to a diagnosis of crossed renal ectopic in a scan, again, the first clue will be not finding one-sided kidney. Then when you look for, you will be able to see one more reniform structure just adjacent to the previous kidney as shown in this video, or it can lie somewhere down. This picture shows this image shows the normal lying right kidney, and just adjacent to this you can see one more reniform shape, and it is fused with the, it is common for the other kidney to fuse with the lower pole, but any form of fusion is still possible. And like I said previously, adding color Doppler has made our job a little comfortable. And this case, we identified it as a cross renal ectopia by just applying the Doppler. Then only we were able to appreciate it in a transvaginal ultrasound. Okay, you have made a diagnosis. Again, you have looked for all other systems and all other markers. And if it is an isolated cross renal ectopia, you can counsel the patient that it has got a good prognosis. And like any other fusion abnormalities, this can also be associated with vesico-ureteric reflex. So we need to follow them up every 4 weeks. And the risk of recurrence in a cross renal ectopic is nil. Anyway, you are supposed to do a postnatal ultrasound to rule out for any genital anomalies. Okay, coming to the next topic, that is ectopic kidney. This happens when the kidneys are formed here and they fail to ascend up to the renal fossa. What will be the ultrasound finding? Again, here, one-sided fossa will be empty, and you will find either the bowel or the adrenal lying down. You will appreciate the lying down adrenal signs. And when you search for other kidney, this can be aided with a color Doppler. You will be able to identify the kidney in an ectopic location. The most common ectopic location being pelvis. So if you see an absent renal fossa, the first area to look for will be the pelvic region just below the bifurcation of the aorta. Here, as you can appreciate, the bifurcation was here, and we were able to pick up the pelvic kidney just below that, above the bladder. This is the common location of the ectopic kidney. But ectopic kidney can be anywhere. The ascent can be arrested anywhere along the iliac, or it can cross and be in the opposite side, or sometimes it is also being appreciated in the thoracic cavity. Here also, we need to look for other abnormalities, but they are very rare. In case of ectopic, associated abnormalities are very rare. Risk of aneuploidies, that is chromosomal abnormalities and syndromic association, is very rare. And you can very well counsel the patient that the prognosis will be very good, and we need not offer them any invasive testing. And the risk of recurrence in them is almost negligible. Coming to the last topic of today, ureterocele. Actually, how do a patient, what is ureterocele? It is the cystic outpouching of the terminal part of the ureter. How do patient present to you? They may present with features of obstruction. You can have renal pelvic dilatation or hydronephrosis. When you evaluate for a RPD or a hydronephrosis, you have to give importance to bladder. Any renal abnormality, it is always kidney, ureter, bladder, fluid. So when you are imaging the bladder, you will identify a small cyst-like structure inside the bladder. This is what we call it as a bladder within bladder appearance. And this will help us to identify, come to the diagnosis of a erythroceal. Actually, erythroceal is of two types. It's sometimes it is single, but in about 10 to 20% of the times, it has a duplex collecting system with the upper system showing features of abstraction. That is, you will have ureteric dilatation. This pelvic system can be dilated, and the lower moiety usually appears normal, but they are at an increased risk for reflex. So now you have identified that this hydronephrosis is due to erythroceal. Then what next? As usual, look for other system, other markers. And association of erythroceal with chromosomes or syndromes is rare. So you need not offer them any invasive testing. And follow-up is very important, because if they are going for an abstraction and hydronephrosis, then we have the option of perinatal treatment in utero. You can do a cystoscopic erythroceal excision. This is done in 1 or 2 centers in India as well. Okay. So every 4-week follow-up is important to arrive to look for hydronephrosis and to assess if there any intrauterine intervention is needed. Otherwise, if they don't develop any hydronephrosis, erythroceal, we need not worry, and obstetric care and postnatal care is as we do for a routine RPD cases, where you will do a ultrasound scan 3rd or 5th day, assess for again hydronephrosis, and if it is not there, you will wait and watch. But if it is progressing, postnatally also, it is advised to remove, do a cystoscopic ureteric myotomy or removal of the cyst. In some cases, where this ureteric implantation site is very much involved, they may need a ureteric re-implantation. Risk of recurrence is negligible, so you can counsel them accordingly. To take home point, if there is one renal abnormality, always look for bladder, ureter, fluid. Next thing is to look for other markers of chromosomal abnormality, other system abnormality. Classify them if it is isolated or associated. If it is isolated, in most of the cases, we need not do any invasive testing except for horseshoe kidneys, where even if you find an isolated horseshoe kidneys, it is always advisable to go for a invasive amniocentesis and at least a karyotypic. Follow-up in most of the renal diseases is very important, because in the initial visit, you may not appreciate something, but you may appreciate that at a later gestation, because hydronephrosis, reflex, all these are going to manifest only after 24 to 28 weeks. Always ask the parents for a renal assessment, because it will give us a clue if it can be a genetic association. Then you need to involve the genetician as well and come to get a holistic investigation, so as to arrive at a diagnosis, and so we can counsel the parents if the chance of recurrence in the subsequent pregnancy is there, or how much it is. And with this, thank you.
Hello, ma'am. I think Dr. Malti madam's turn to sum up the proceedings if Dr. Selupriya madam is not reporting.
Dr. Selupriya is not here. She's supposed to talk on fetal hydronephrosis, but I think Dr. Renuka covered everything like horseshoe-shaped kidney and crossed fused ectopic. I think horseshoe, it's important to look to do the amniocentesis because very often we found turners in horseshoe-shaped kidneys, and renal agenesis is always better to evaluate for microarray followed by termination. So, as few things, as she said, some of them will not require investigation because the risk of recurrence is very low. But some of the disorders have a high risk of recurrence, and based on the conditions, we have to do a further assay. Dr. Sita Paul, would you like to add something?
No, that's fine. I think she's covered everything very nicely. Yeah.
Thank you, Dr. Renuka. Any chairpersons would like to comment?
We're not going to have Selva's talk, is it?
Well, she's not, we're not able to reach her by phone
That's
or
right. Okay.
some family emergency.
Yeah.
Actually, I wanted someone to talk on fetal hydronephrosis because of the.
That's something so very common.
LV calcite separation. What should we do? Should we continue?
Yeah.
Should we? There are a lot of myths, but I think in the second trimester till 4 mm, beyond 4 mm, we call it as mild PCS. Beyond 7 in the third trimester, we call it PCS, but nothing to worry because 80% is going to resolve. Only the 20% is the one which is going to progress. But always ask for a review scan every 4 weeks because sometimes even a PCS as low as say 5 or 6 can progress to hydronephrosis in the third trimester.
Yeah.
And this hydronephrosis is not going to do any harm because most often we find that the prognosis is good. We do a neonatal ultrasound on day 5, and based on the situation of the hydronephrosis, then we offer a pyeloplasty surgery. But the gross hydronephrosis, I think the prognosis is very, very bad because the kidneys are unlikely to function in the neonatal period. So mild, moderate, severe is a way of classification of hydronephrosis, and based on the severity of the hydronephrosis, we can prognosticate and doctor the patient. Most often, for gross hydronephrosis, when we see them in the second trimester, the only option is termination, and we have to find out the cause for the hydronephrosis, whether it's a pelvic junction obstruction, whether it's a megacystic bladder, or whether it's a just a vesical ureteral reflux. So finding out the cause is important, but the prognosis of gross is always going to be bad and unfavorable. Mild and moderate, generally, we look at the pelvis, we look at the callosal dilatation, we look at the CMD, we look at the parenchymal thickness. Based on these 4 or 5 parameters, we do a staging, a stage UTI stage 1, A1 to A2, A3, A4, and that is going to help us in the prognosis. So looking at the pelvis alone is not enough. We have to look for the peripheral and central callosal dilatation, which is going to help you in prognosticating because we get a lot of cases of PCS, but when you do a coronal view, you find a pelvis and callosal dilatation both. And based on these stages of UTD classification, we prognosticate and offer counseling to these patients. Okay, Sita Paul, you want to add something on?
I would like to add that yes, there's a standardized way of reporting these, as Dr. Malati said. It's UTD A1, which are the milder ones, and the most severe ones are UTD A2 and 3, where there's associated callosal dilatation, hydroureter, and the other findings. But the most important thing is to remember is that the LICA volume remains normal. It's a very good sign that this baby is going to do well. So there is, please do not do an iatrogenic premature delivery just for these causes, because if the LICA is good, these babies, have to be taken till term, and they don't need an early delivery for that. And definitely involve the pediatric urologist antenatally if need be, so that they get a better positive picture of the whole scenario, and then decide postnatally whether they need scans. And most of them will do well if it's within, if the kidneys are normal, if the dilatation is mild. Yeah, that's what I wanted to add.
Yeah, just looking at a pelvic calcium separation, you don't have to alarm the patient because patient is so worried that my kidneys are enlarged or whatever. It doesn't matter at all. As long as we classify properly and treat.
There's one more thing I want to add, that it's a very common second trimester soft marker for aneuploidies, but isolated. It's always important to look at these soft markers, whether they're isolated or associated with other soft markers. So if there is renal pelvis dilatation with other things like short femur or absent nasal bone, then definitely you would need invasive testing. But if isolated and everything else is fine, you can reassure. The other important thing to note is that if we have if the NIPT was done earlier, if it was low risk, and then you find a renal pelvis dilatation, there's really no need to interrogate in terms of trisomy 21, because NIPT is very good, but you have to follow up these patients with a rescan at 28 weeks to make sure they're not progressing to more severe dilatation also. That's all.
As the multicystic dysplastic kidney, I don't know, multiple cysts not communicating with each other.
Yeah.
There is a hydronephrosis, we'll have
Typically
multiple,
communicates.
they all communicate with each other.
Yeah.
That's a only differentiating point between a gross hydronephrosis and a MCDK. If they do not communicate, it's MCDK. If they communicate, it's a hydronephrosis. So that's how we usually differentiate and prognosticate accordingly.
Yeah.
I think sort of we have summed up hydronephrosis. Yeah. Okay.
Thank you.
Thank you,
Thanks,
Chairperson.
thanks everyone.
Thank you, ma'am.
Thank you,
Thank
madam.
you, Chairpersons. Thank you, Dr. Sita, Dr. Tamichelvi,
Thank
Dr.
you, ma'am.
Dhanlakshmi, ma'am.
Dr. Malcolm.
Thank you,
Yeah.
ma'am.
Dr. Radhika for
Thank
doing the
you.
MC. Thank you very much.
Thank you, ma'am.
Bye.
Thank you, ma'am.
Thank you, Dhanlakshmi.
Yeah.
thank you.
And if it's possible, you'll get a recording of this, Dr. Malcolm.
Yeah. We will send it to you. No problem.
Thank you.